Okay, guys, final lecture for this series. A couple new drugs to talk about today and some old favorites. Antiarrhythmic pharmacology has to do with manipulating the cardiac action potential. And you can do that a couple of ways. Sodium, potassium, and calcium channels all can be manipulated, and beta receptors can be manipulated. So actually, beta blockers and non-dihydropyridine calcium channel blockers like diltiazem and verapamil are technically antiarrhythmic agents. So there's two of our major classes already. The other two classes, sodium channel blockers and potassium channel blockers, we're going to talk about in a lot of detail today. The different phases represent different options for us pharmacologically. I'm not going to go through a ton of this, as this is more pathophys, but it is on here for your reference. And just some heart anatomy as well. So we're changing the way things move through the heart and trying to rearrange the electric signaling so that we don't have an abnormal rhythm. Basically it. And then our different phases here. So I'll talk about which phases the drugs work in. So for example, class 1s have some maybe more effect on sodium channels in phase 1. Class 3 maybe more impact on potassium channels in phase 3. Okay, anyway. Drug classes. Class 1 are sodium channel blockers, and here's some ways that they work. Oh, I kind of just lied on that. See, that's why I shouldn't talk about pathophysiology. Basically, class 1 seems like are either working in slow phase 0 or having effects on phase 3. Beta blockers don't really do anything with a specific phase, but they reduce rate of spontaneous depolarization in SA and AV nodes. Beta blockers are not really used as an antiarrhythmic with the exception of one called sotalol, which also has a separate mechanism in addition to its beta blockade abilities. Class 3, potassium channel blockers prolong phase 3 repolarization, and class 4, calcium channel blockers reduce rate of spontaneous depolarization in SA and AV nodes, similar to beta blockers, and similar in the sense that we don't use them as actual antiarrhythmic agents. However, a lot of times, let's say you get somebody in the emergency department and they're in Afib, they have a rapid heart rate, you give them some diltiazem to slow it down. Sometimes those patients just convert out on their own. So it does have some, just by reducing the rate, you can have an antiarrhythmic effect in and of itself. Okay. Antiarrhythmic uses. So atrial fibrillation, ventricular tachycardia, ventricular fibrillation. Overall risk with doing this is you are manipulating the way the electric signaling goes. So you can prolong your QTC interval, which can lead to a VTAC or a polymorphic VTAC like torsades, and that is life-threatening. So we want to make sure we're monitoring a number of different things when we give somebody antiarrhythmic medications. Okay, talk about the drugs and talk about where they fit in a little bit. Class 1A antiarrhythmics aren't really used that much anymore, so I'm not going to spend a ton of time on them. Every once in a while I see somebody on procainamide or quinidine, but it's really odd. We had somebody on quinidine recently in the hospital, and I had to call all over the metro area to try and find the drug for them because we didn't actually have any in stock. So it's not common, and that's all I'm really going to say about this. Class 1B antiarrhythmics, a little more common. Lidocaine is mostly used as a topical anesthetic, but it has some utility as an antiarrhythmic. Really, the only time we use lidocaine is for pulseless VTAC, VFib conversion. So this is going to be a cardiac arrest situation. It's an emergency-only medication. It's not used for really anything else. So again, I'm not going to talk about it. Mixillotine's occasionally used for people who have struggled with VTAC chronically. It is a Q8 hour med, and not super common to see that one either. All right, class 1C, getting a little more common, propafenone and flecainide. Two somewhat more common antiarrhythmics. In general, class 1 antiarrhythmics aren't really common. They're unusual to see, and I think the not newer drugs, but the potassium channel blocking agents are just much more effective, and they're relatively well tolerated. So it's not uncommon to see these, but it's getting more rare. I feel like flecainide used to be a more common medication, not so much anymore. As far as the side effect profile of these ones go, flecainide does have a decent profile. It does cause some dizziness. It can put you at risk for acute diastolic heart failure, which is why it is contraindicated in heart failure. So these agents technically have some negative inotropic activity, which you never want to give a patient with heart failure. So if somebody has heart failure and arrhythmia that you're trying to treat chronically, you don't want to give them one of these agents. So that's something to remember about flecainide. Otherwise, for a healthy patient, flecaine's not a bad drug for Afib maintenance. It doesn't have a lot of side effects, doesn't have a lot of drug interactions. It's relatively well tolerated. It's not as difficult to start somebody on a regimen or monitor for as some of the other medications that are a little bit more popular we talk about. So flecainide could be an option. I had a professor way back when in school say that flecaine's like a great drug again for that healthy person who doesn't really have anything else going on but just Afib. So definitely something to consider. These drugs both have a pill in the pocket strategy approved, and what that means is you carry a large dose of flecainide, so like triple what your daily dose would normally be, and you take it all at once if you feel like you're going into Afib. It's got a 40 to 50% chance of converting you out of it on the spot. Obviously not as good as going into the hospital and getting cardioverted with electricity, but not bad either for a drug that doesn't have a lot of side effects. You don't really risk much by doing this, and it certainly can work well for some patients. All right, class 3 antiarrhythmics. Amiodarone is one of the oldest and most popular antiarrhythmics still on the market. It's a really broad spectrum antiarrhythmic. It actually has all type of different class effects, which is likely why it's so effective. So it's not only got some sodium, so it's primarily a potassium channel blocking agent, which is where we classify it, but it also has class 1. It's somewhat of a beta blocker and a calcium channel blocker too. So yeah, you're like, how can you give somebody a drug that does all that and not completely stop their heart? Well, that's a good question. It's all about the dose, right? And amiodarone certainly is toxic. You don't want to overdose somebody on it, but it is a really potent medication. You can use amiodarone not only for conversion of atrial fibrillation and maintenance of atrial fibrillation, but you can also use it in acute cardiac arrest too. So again, it's got a lot of applications. It's a really good one to remember for this lecture, just as being essentially applicable in almost any situation you can imagine. Now, amiodarone kind of comes with some nasty adverse effects. Chronically, pulmonary fibrosis is something that's seen in about, depending on what study you read, 3 to 70% of patients, and it can really lead to severe pulmonary dysfunction. And it's something to think about when you're prescribing amiodarone. I had a professor also say, when you prescribe somebody an antiarrhythmic, amiodarone's great for an old person because most of the nasty side effects take a long time to see. So pulmonary fibrosis isn't going to happen overnight. Thyroid issues aren't going to happen overnight. These are going to take a while to see. The reason why amiodarone interacts with the thyroid is because it has some iodine moiety on it, and so it does interact with the thyroid gland and can be thyroid toxic over time. It's neurotoxic in chronic cases. So again, taking it for 20, 30 years might not be the best idea. It causes some eye issues, can cause liver issues, can cause chronic CV decline and blue-gray skin in 15% of patients. I've only seen this once where somebody came into the ED and people thought they were cyanotic, but they really just run amiodarone. It's rare. I think it's a lot rarer than 15%, but maybe there's some subtlety to it, I suppose, in some patients that have very slight tinting of the skin. But for most people, I don't think you really see that side effect. But when you do see it, you'll remember it. Amiodarone doesn't have any contraindications for use in heart failure, so there's an option for a heart failure patient there. It does contraindicated for people with hyperactive thyroid disorders and iodine allergies, though. Amiodarone, to continue some of its weird, this is just a very bizarre drug. So it's one I don't think anyone should ever really forget because there's a lot of interesting things about amio, and it's so popular that it's a good one just to know all its intricacies. So that's why I'm spending a couple slides on it. Drug interactions. So it's a moderate inhibitor of a couple different popular CYP enzymes. So anything else you give somebody, like warfarin, digoxin, statins, phenytoin, which is anti-seizure med, lidocaine, we don't really care about. But warfarin is one of the most popular anticoagulants that atrial fibrillation patients get. So it's a big deal to give somebody amiodarone. It's a really common drug-drug interaction. And to complicate matters, it's got a 58-day half-life. That's not a typo. So when you start somebody on amiodarone, it takes like a few weeks to really see those drug interactions fully come into play. So you really have to monitor somebody's anticoagulation status if they're taking warfarin really carefully. And that's really going to be the biggest drug interaction you're going to see. Of course, there's other things with amiodarone. Every once in a while, something flags on when I'm verifying something, like, oh, like what was it the other day? Colchicine, which is a treatment for gout flares, is contraindicated with amiodarone use. I didn't know that until I saw it on my electronic medical record, and I paged the doc, and he's like, oh, I didn't realize he's on amiodarone. I'll change it right away. I'm like, oh, okay. I didn't really realize that was even a thing, and I'm an idiot for being a pharmacist and not knowing that. But amiodarone's a good one to just remember. Drug interactions, and because it lasts such a long time, you compound those effects. So it's going to be a chronic thing you have to balance with these patients. Now, once you get somebody on a stable warfarin regimen and a stable amiodarone regimen, you don't have a lot to worry about. Dosing. So the dosing gets interesting, and you're like, it takes 58 days as a half-life. I thought it took 3 to 5 half-lives to get to steady state. How does that all work? Great question. What we do with amiodarone is we load it in people. So you can either do an IV loading dose, which if somebody's pulseless, having a cardiac arrest, you just push it in. Otherwise, you give it over a certain amount of time, and then you can do a continuous infusion. It takes a few hours to get the whole thing in. Other thing you can do is do about 10 grams oral over 5 to 7 days, and then people are going to be on 200 to 400 milligrams maintenance. Again, not testing on the doses, but just giving you a feeling for how we load people. So people are front-loaded on amiodarone. The idea by doing that is you can overcome that really slow, steady-state buildup and hopefully get the person therapeutic quickly. Turns out, even though it's got a weird kinetics, if you push a ton of it into somebody intravenously, you're going to get pretty good effects pretty rapidly. So amiodarone is a very effective antiarrhythmic in a lot of cases. I'll say that one more time. And I've had a lot of codes that I've been in where amiodarone, well, not a lot, I'd say a couple codes where amiodarone, I feel like, turned the tide in the code, where you do all these other things for a cardiac arrest, a pulseless VTAC or VFib, but amiodarone seems to be the thing that is antiarrhythmic, and it's probably got the best chance of actually restructuring that rhythm, outside of electricity, that is. Doesn't increase mortality in heart failure. Again, this is a big thing for heart failure patients because they can take amiodarone safely. It's not a negative inotrope. And again, very highly effective. So despite all its idiosyncrasies and side effects, it's still a really good drug. Okay, the other side of the coin, dofetilide is the other one that's popular. So really, if you're thinking about this lecture and getting confused already, I really want you to know basically 3 agents. Flecainide, dofetilide, and amiodarone. Now maybe Propath, or go back to my other slide here, so you get this, what I'm talking about. Maybe propafenone as well. So really I'd focus on the 1Cs. I'm not going to test you a lot on this stuff. I might throw them in as a wrong answer or something, but I'm not going to ask you to classify and prescribe somebody a 1A or a 1B. It just doesn't make any sense from my perspective. So from a learning perspective, I really want you to focus on amiodarone and dofetilide and know a little bit about flecainide too. If you can do that, I think you'll be okay for my antiarrhythmic portion of the exam. Dofetilide is brand name Ticcasin. It's the newest one. Well, the newest one that we use a lot. Its use is mostly in just Afib for conversion and maintenance. It doesn't come as an IV agent. And it does have some issues with prolonged QTC interval, which can again lead to a polymorphic VTAC, aka torsade de points. I don't know French, sorry. I don't know French. I don't speak French. Torsade de points, I think is how you say it, but it's spelled points. Anyway, I'll stop talking now about that. So you have some issues with QTC prolongation with this. With amiodarone, you don't really see QTC prolong as much, but it certainly is possible. With this drug, it's sort of notorious. So it also is renally eliminated. So if you have renal issues, you're not going to be able to take dofetilide, where you could take amiodarone, dose adjust properly. Contraindications. So baseline QTC greater than 440. If you don't have that contraindication and you can start this drug, you're going to give a dose and monitor QTC 2 to 3 hours after the first 5 doses. If the QTC increases by 15%, then you cut the dose in half and keep going and see what happens. If the QTC ever gets above 500 milliseconds, you do not proceed with therapy and you consider it a failure at that point. This drug also is okay. It does not increase mortality in heart failure patients. It is CYP3A4 metabolized, so it's highly prone to drug interactions, which isn't great when you're talking about an antiarrhythmic agent, but it is what it is. So back to my comment about a professor who said, for an older patient, amiodarone is a great drug because most of the side effects are long-term. For a younger patient, dofetalide's a much better option. It really doesn't have any long-term side effects like amiodarone. It doesn't have those weird pulmonary fibrosis or all those crazy things that happen if you take it for decades. It's actually fairly safe. If you can get by this initial stuff with these QTC issues, you're fine. This same person who told me this also argued that amiodarone is a better drug for the elderly because they don't have to go through all this issue with possible QTC fluctuations that you might get with dofetilide. Now, I don't know if I totally agree with that, but either way, dofetilide definitely has an advantage in the long-term side effect profile. Amiodarone probably has an advantage in that it's highly effective and it doesn't have quite as many issues with its ramp-up phase with the QTC prolongation. Now, we do sometimes see people who are on amiodarone who need to switch to dofetilide because of side effects. In that case, you have to basically wash amiodarone out. I think it's like a 90-day period where you haven't been on amiodarone and before you can start dofetilide. It's quite a bit of time. I don't know off the top of my head, but I know it's at least a month or two, and I want to say it's 3 months just because of that really long half-life. If you give the two at the same time, you do risk compounding this effect, and that can be severely problematic. And you might just need to wait till that amiodarone washes out to see that QTC come down to a normal amount. Sotalol is a beta blocker, but also a class 3 antiarrhythmic. Sorry, so this is the other one I want you to know. I just said you don't need to know anything else other than these three. Well, sotalol you should know too, but we already talked about sotalol very briefly. So it's under your beta blockers. It's a potassium channel blocker as well. It's very similar to dofetilide as how it started. Baseline QTC things, you got to monitor QTC while you're inpatient to avoid arrhythmias, and then basically it's the exact same protocol as dofetilide. No difference there. Dronedarone, I don't care that you know this drug. It came out, I think everyone thought of it because it sounds kind of like amiodarone as an amiodarone similar agent. It's supposed to be similar design to amiodarone without the side effects. It didn't really pan out that way. It does cause worsening heart failure, so it's contraindicated in heart failure. It has some other issues. It's just not as effective of an agent, I think, as they wanted it to be, so I don't think dronedarone gets a ton of use. I'm not going to test you on dronedarone. It's not super common. Other antiarrhythmics, this stuff gets into more of our acute care management, and I don't really want to spend a ton of time on it because it's not relevant for this particular exam. I would like you to know generally that these drugs can be used to stop arrhythmias. So we can give IV magnesium if somebody does get into that polymorphic VTAC or torsades. You can give them a shot of magnesium. Adenosine is another one that can stop supraventricular tachycardia. You give it IV push. Again, we're going to come back to all this during emergency medicine, so I'm going to kind of blow through it right now. Let's talk about Afib for a while. So Afib is irregularly irregular, no distinct P ways. Paroxysmal Afib is defined as 2 episodes that terminate in 7 days or less, usually within 24 hours. Persistent would be do not self-terminate in 7 days. 50% of patients with paroxysmal will convert to persistent in about 10 years, even on antiarrhythmic therapy. So once somebody starts getting Afib episodes, they're probably going to develop it as a chronic condition at some point, but it might take several years to get there. So maybe they're coming into the ER twice a year to get cardioverted. Okay. Eventually that might become twice a month, twice a week. You know, it might get more consistent that to the point where they're always in Afib and you can't shock them out of it. Okay. Basics with Afib. Afib is an arrhythmia itself, quality of life issues, exercise intolerance, fatigue, palpitations, dizziness, and syncope. Thromboembolism is the biggest long-term risk with Afib. So what you do is your atria aren't beating and clearing blood like they should, so you get blood pooling in there, which allows clots to form. And then in the case of those clots moving, you can get sudden clots moving to other places in the body, and most frequently into the brain. So stroke risk is huge. Ischemic stroke risk is huge with atrial fibrillation. Rhythm versus rate control strategies is the question that we're going to talk about. So do you control the rhythm and just ignore the arrhythmia? Because the arrhythmia itself, if your heart's not beating as fast, it's not as noticeable, and people might be able to tolerate it just fine. Or and that's more of a rate control strategy. Or do you give an antiarrhythmic and actually try and get that rhythm back into sync, into a normal rhythm? Anticoagulation, chronic AFib will require oral anticoagulation. Warfarin is targeted INR targeting, and there's a lot of newer agents too that we're going to talk about next week. So where do you give people anticoagulation? For the vast majority of AFib, people are going to be on warfarin. You'll see that somebody with no CHADS2 or CHADS2 VASC, so the CHADS2 score, the old CHADS2 is this. The CHADS2 VASC is what's used now, and that's what these criteria are. So it's similar, just adds some different things to it, and it gives some different point values for some other things. So basically, you'd have to have 0 to not be on warfarin. The odds of anyone with AFib having 0, probably, I don't know, it's possible. Certainly if you're a younger, healthy male patient, but if you aren't, you're probably going to be on warfarin. So again, I said here that chronic AFib will require oral anticoagulation. That's kind of a lie, because if you didn't meet any criteria, you could just be on aspirin, which is just an antiplatelet agent. Or if you even have one, it's debatable whether you should be on warfarin. But again, the vast majority of patients you see will require anticoagulation. And by warfarin, that doesn't mean they have to be on warfarin. They have to be on a anticoagulant. Most patients historically have been on warfarin, but our newer anticoagulants are sort of taking over, and warfarin's not as popular of a choice anymore. All right, determining a course of treatment for AFib. So if you have new onset AFib with mild to moderate symptoms, you want to start with rate control as needed. So to rate control, we use IV or oral, depending on how severe it is, diltiazem. I say diltiazem / verapamil because technically you could use both, but diltiazem's preferred agent. I always see diltiazem used. You could use a beta blocker, which I don't see used very often at all. I'm not entirely sure why. I don't know if the evidence is bad, but it's not a popular choice for this, which strikes me as odd because I feel like it'd be a good option for rate control. Digoxin is another one that can put people's rate back into place pretty quickly, and it's sort of an old school treatment, so some of my older providers still like to use like a big dose of IV digoxin, and it's certainly an option. I think diltiazem is by far and away the preferred choice though. Okay, so you're rate controlling the patient, you evaluate the patient for rhythm control options at that point. So your rhythm control, whoops, wrong way. Rhythm control could be patients who may spontaneously cardiovert into normal sinus rhythm with rate control alone. So that person doesn't need anything done. The rhythm control strategy does not necessarily have any benefits over rate control plus anticoagulation. So they've trialed whether, let's say you have somebody come in with AFib and you say, okay, let's either put them on anticoagulation and rate control them and send them home, or get them out of this rhythm. There's not really an end outcome difference in that. Most patients, if it's like their first or second, or even they get, one episode a year, certainly I would highly recommend cardioverting them. But if you have somebody who's chronic, that's where it gets a little bit different. So what patients, this is a clinical judgment call in a lot of cases. If they have low risk for recurrent AFib, a one-time pharmacologic or electric cardioversion is probably ideal. If they have troublesome symptoms despite adequate rate control, usually requiring chronic antiarrhythmic therapy, or recurrent AFib totally, that would be a case for rhythm control. Why the concern? Cardioversion does put the patient at risk for a thromboembolic event. So if you think about it, you've got blood pooling in somebody's atria, and you shock them out of their rhythm, and their heart starts beating, and their atria all of a sudden starts beating normally. It throws that clot straight into the brain, and you give the patient a stroke. So that's the big issue here. We'll talk about how the criteria for that in a second. First, though, long-term rhythm control. What do we consider the first line? So we just talked about all these agents. These are our drugs to consider here. So no structural heart disease. Remember flecainide, good choice for these patients. Heart failure, amiodarone or dofetilide. Coronary artery disease, sotalol. Amiodarone, dofetilide. Hypertension, flecainide, amiodarone, dofetilide. Obviously, if somebody has hypertension and heart failure, you'd bump into line 2 here, and those two would be the first line. So again, pretty much the 4 drugs I want you to know: amiodarone, flecainide, sotalol, and dofetilide. If you got those down, you're pretty good. If you know propafenone and flecainide exist in the same category, that's also good to know, I think. Okay, so you have somebody with AFib and you want to rhythm control. They're stable and they've been in AFib less than 48 hours. So this is a person that walks in, they're in AFib, and you want to cardiovert them. You want to start with DCC, aka direct current cardioversion. So this is electricity. If the person has some contraindication to anesthesia, and by anesthesia, when you cardivert somebody, you're basically just giving them a very mild sedative like propofol and a small dose of it. It's called a conscious sedation. They aren't intubated. They're breathing on their own. You aren't paralyzing the person. You're just putting them to sleep for like 10 minutes at most. It's very quick. But if they have a contraindication of that for some reason, you could consider a pharmacologic conversion, which there's a couple options we can try there. Anticoagulation is not required for these patients. They haven't been in AFib long enough to consider a clot risk. You really have to be in it for greater than 48 hours or an unknown duration. So if you have a patient who's stable and you want to cardiovert them, you either have to, and they've been in AFib greater than 48 hours, or you don't know how long they've been in, you have to consider something. So are they anticoagulated in the first place? Maybe they're on an anticoagulant and they're fine. You don't have to worry about it. Are they not anticoagulated? You can confirm the presence of a clot with a transesophageal echocardiogram to see whether there's a clot in the atria. If you can clear that there's no clot there, go ahead and cardiovert. If there's a clot there, or you can't get the TEE done, then you have to rate control and anticoagulate for 3 to 4 weeks. So you want to give 3 to 4 weeks for that anticoagulation to allow it to make sure that that clot doesn't get bigger. Now it's a little weird because I don't know where exactly the clot's supposed to go, but they've because you aren't breaking down the clot. What I understand it is it makes sure the clot doesn't get big, doesn't get larger for one thing, and anticoagulation also will allow the body to naturally break down the clot. So your body's going to work on getting rid of that clot. Your anticoagulant's going to make sure that that clot doesn't get bigger, and then you should get rid of it in 3 to 4 weeks. You can always do another TEE to confirm, but generally speaking, that's the standard of care. So the clot should be gone in 3 to 4 weeks, assuming your body's doing its job. And then you can bring the person back in and cardiovert them. Rhythm control. Okay, so this is a stable person and chemical cardioversion as an alternative to direct current. So this is somebody who's been unknown or greater than 48 hours, and we don't want to do electricity. So you have to still anticoagulate these people because you're still going to cardiovert them. If they're in AFib for up to 7 days, you may chemically cardiovert with flecainide, dofetilide, propafenone, ibutylide, or amiodarone. I kind of blew past ibutylide. Basically a IV version of dofetilide that you can, it's not quite the exact same thing, and it's not done as like a loading dose or a ramp up period. It's really just a one-time cardioversion type thing. If the person's in AF greater than 7 days, chemically cardiovert with dofetilene, ibutylide, or amiodarone. You notice that your class 1, flecainide and propafenone, drop off here just because they aren't potent enough. And if somebody's been in AFib a long time, it's thought that these drugs are the only ones that are really going to work, and that you kind of lost your chance with the less potent 1A or 1C options, excuse me. Okay, so let's say you have a new onset person with severe symptoms. This is really uncommon. I don't know if I've ever seen somebody come in with AFib who I'd classify as severely unstable, but it's possible they're just not doing great. Maybe an older person, or somebody who's just kind of frail in general, or has a lot of underlying comorbidities going on. Either way, the person has severe hypotension, angina, pulmonary edema, so maybe a heart failure patient with acute diastolic heart failure on top of an AFib. That could be a potential scenario. You want to get them IV heparin, get them heparinized as best as possible. The idea is that that clot hopefully won't grow anywhere and that it won't expand, and then you just want to convert them as soon as possible. So they're heparinized, they're anticoagulated, it's the best we can do, but they're super unstable. The risk of throwing a clot into the brain does not outweigh the benefit of cardioversion, getting this person out of this rhythm that's technically life-threatening at this point. Again, very unusual with AFib to see this happen, but it is possible. A-flutter is kind of similar to AFib. You rate control, and usually ablations are most, you can shock people out of flutter, but ultimately long-term therapy, as far as what I understand, ablations are the preferred thing where they actually go in and kill the cells that are causing the problem. Okay, that's it. If you're confused on the anticoagulation part, just hold tight. The next lecture, I'll try and post it soon, will be up. prior to next week. We'll talk a lot about anticoagulation and go through all those details next week for your benefit. So without further ado, that's it for this week. Let me know if you have any questions, and I'll see you next week in person. Thanks.